Hello, welcome to Ashby Village Science and Ideas Group. We have monthly presentations. The group was founded in 2017. All of our members, and we have around 36 right now, have varied educations and work experience backgrounds, but we all have one thing in common. We all have a keen interest in science and new ideas. We meet every Thursday, the second Thursday of each month. Second Thursday of each month from 3 o'clock until roughly 4:30, depending on question time. We have a different guest speaker each month who speaks on a topic related to science and ideas. We rely on our science group members in the Ashby Village Arts and Culture Committee and all Ashby Village members to give us ideas about new speakers, and then it's my job to contact them and see if I can get them to agree to make a presentation. To give you an example of the kind of things we do, in the past, we've had a presentation on COVID-19 vaccines and what is the forefront of that by an actual vaccine researcher doing that work today. We had someone speak on what's beneath the surface of Lake Merritt, a lake here in Oakland. He talked about literally 1,000 different life forms that live under a lake that most of us just ignore and walk around. We had someone talk about the effect the internet is having on our attention spans. We've had an astronomer talk to us about asteroids and the chance of one of them hitting the Earth. We've had several talks on the great migrations out of Africa millennia ago into Europe and the East. We invite all Ashby Village members to join our group. Others interested also are welcome to attend our presentation. You just send me an email. Hillary will provide my email, and I'll see to it that you're invited to any particular meeting or all meetings. Now it's my pleasure to introduce Dr. Stephen Cantor. Dr. Cantor has had a wide range of experience from he's very academically oriented in the field of cardiology. He's done research with UC Davis. He was in private practice here in Oakland for a number of years. He has taught as an associate clinical professor of medicine at UCSF and later on at the Midwestern School of Osteopathy in Glendale, Arizona. With the rapid increase in managed care, Dr. Cantor moved his practice to Prescott, Arizona, to start up there, which was and is a growing community in the high desert of Arizona. And of course, there's a distinct need for contemporary cardiovascular care in that community. And he's brought along with him the latest insights and developed state-of-the-art cardiology and cardiac surgery program. So we want to welcome Dr. Cantor to speak to us today and share his somewhere around 50 years experience. Dr. Cantor retired several years ago and is kind enough to come speak to us today. Take it away, Dr. Cantor.
Thank you, Joe. Well, good afternoon, everybody. Ashby Village Group. Pleasure to be with you. So the topic of the talk is heart failure, and the reason for this topic is that heart failure is ubiquitous. It's really everywhere. To give you an idea, there are about 6.2 million adults in this country living at this time with heart failure. That's a lot of people out of 330 million. I think you'd agree. The other point is the most common reason to be admitted acutely from the emergency room to an inpatient setting is in fact heart failure. So that's how common it is. It really is common. I'll talk to you about it from, I'll put it in lay terms as much as I can. And I know Joe's going to interrupt me if it gets a little technical. To me, of course, this is pretty straightforward. Because I lived it and worked it for a long time. I'm going to talk to basically the changes, which were most of the changes. I finished work in 2018. There's been one particular change since then, but that's relatively minor. So what is heart failure, in fact? Well, it's when the heart fails to either fill or pump and eject adequate blood supply to the circulation and to the tissues requiring delivery of blood. That's its role. As a youngster, young doctor I'm talking about, we always used to think that heart failure was due to a weak pump. That's what we thought. And I think the natural history of disease changes over a period of time, and 50 years is long enough to see that. Now the frequency of heart failure with a stiff heart versus a weak heart is about the same. It was in the 1980s, I think it was, when we started to look at hearts visually from a non-invasive perspective. And then we realized that what we thought was one thing, in fact, was two things. I will say this for the heart failure with reduced ejection fraction, there is nothing yet that we can, I'm sorry, back up. Heart failure with a stiff heart, there is nothing yet directly we can do about the stiff heart. So we basically treat the complications of the heart failure and the effects of it. The heart failure with reduced ejection fraction has gone through a rapid transformation, and I'll present mostly about that. But let's go to the next slide, Joe.
All right, so just a moment.
Okay.
Okay.
All right, so this is the basic structure of the heart, and I'll go through it in a little detail. So the blue-purple colors represents deoxygenated blood that's been through the circulation, disposed of its oxygen carrying capacity, and it returns to the blood to pass through the lungs, pick up oxygen, and then go out in the circulation again. So in the top left, Joe, of this, go to the superior vena cava up there. It's blood returning from the head and neck, and right beneath it is the inferior vena cava, further down. Yeah, that's right. And that's blood returning from below the diaphragm. So it's returned into the right atrium, which is a receiving chamber. And between the contracting cycles of the ventricles, which do the heart's work, the right atrium will fill the right ventricle with opening of the valve. You see the tricuspid valve, and then it contracts, sends blood into the pulmonary artery, which is the top one. You see cross section. That's it. The pulmonary artery itself is out of the plane of this picture. And it's important to realize that the right ventricle is thin, the left ventricle is relatively thick. And the reason for that is that the pressure in the pulmonary artery circulation is low, and the pressure in the systemic circulation, that is the blood flowing to the body through the aorta, is much higher. So just to give you an example, the peak pressure in the pulmonary artery is normally about 20 millimeters of mercury, and the peak pressure in the circulation is what your blood pressure is, which should be 120 or less, is what the gurus say, but it's usually a bit more. So the blood goes from the pulmonary artery through the lungs, picks up oxygen, and returns through the pulmonary veins on the right middle. So yeah, there we go. Pulmonary veins, and there are 4 of them, emptying into the left atrium, which is the receiving chamber for the left ventricle. One comment to make about the pulmonary veins: they don't look terribly big, but they have capacity to store a lot of blood, maybe up to 2 liters of blood. So when we get to treating heart failure, we have that we can work with. A simple example would be use of morphine, which is often given in severe heart failure to relieve patients' distress. What it really does is it dilates the pulmonary veins, and the blood is stored there rather than and the pressure in the pulmonary veins drop. So the backup pressure into the lung tissue is reduced and the shortness of breath is relieved. But that's just a side issue for now. So the left atrium ejects blood at the end of the resting cycle of the left ventricle through the mitral valve here into the left ventricle. The mitral valve has two leaflets, and it's unique in that, like the tricuspid valve, it is attached to the wall of the left ventricle via little string-like structures. We call them chordae tendini, and then to the papillary muscles down here where the strings attach. That's all part of the left ventricle. So we'll come to it later, but when there's damage to the left ventricle, that can affect the competency of the mitral valve, and it can lead to weakness of the valve. So I'll get to the electrical cycle of the heart in a moment, but just finally, the left ventricle ejects blood into the circulation through the aortic valve, which is outer plane here, and then into the aorta and out into the periphery. One point to make is that the resistance to emptying at the left ventricle is fairly low, but there is some resistance, and that's due to the very small arteries as they break down in size. These arteries have a muscular coat which varies, and they are what we call the resistant vessels. The large vessels, like the aorta, are elastic. So as the blood is ejected, the aorta expands. As we get older, the aorta tends to stiffen in most people. That's what is called arteriosclerosis. Sclerosis means it's loss of elastic tissue, and that has certain effects as well. The other point I should make, Joe, on the upper right portion of the right atrium, right, that blue item there, SA node stands for sinoatrial node, and that's the area where the electrical activity of the heart occurs. That is specialized tissue which sends out a signal once per minute, 60 times a minute, and is heavily impacted by both stimulation from the sympathetic autonomic nervous system, and the other way, it can be slowed down quite severely by stimulation through the opposite, the parasympathetic nervous system. I'll talk about that more extensively, but just to summarize, the sympathetic nervous system is the flight or fright reaction, where your heart rate, say you have a panic attack, your heart rate goes up and the blood pressure goes up. That's all related to sympathetic discharge, and that's vital in the function of the heart. Now, the electricity goes through the atrium through basically some specialized pathways to the AV node, which stands for the blue one, Joe, the blue one right there, atrioventricular node. That limits the speed at which the electricity is conducted. And then it goes through that down to the ventricles with one specialized area to the right ventricle called the right bundle branch block, right bundle branch rather, and the other one on to the left ventricle called the left bundle branch. That's important because disturbances of the conduction play quite a key role in heart failure. Okay, that's a lot in one slide. But if you can do 4 chambers, 2 atria, 2 ventricles, deoxygenated blood to the lungs, oxygenated blood to the circulation. Okay, all right. Next one, Joe. Okay, this is representing what actually goes on inside the left ventricle. Let me back up. This talk is about left heart failure, which is the common one. The right heart fails much of the time due to failure of the left heart. If it doesn't fail from the left heart failure, then it's got to do with issues with the circulation in the lungs, either lung tissue disease or pulmonary hypertension, we call it, blood clots, a variety of things that can happen. But I'm not going to talk about that. What I'm going to talk about is left heart failure. Okay, so in the left ventricle, the ventricle contracts for a period of about 0.3 of a second, and then relaxes. That period is called systole. And the interval between the systole is called diastole. That's electrically between. So if you follow the mauve line up the top, that's where left ventricle contracts, then it stops contracting, and the pressure falls down to baseline. This blue line represents the radial artery. It could be any artery, but that's the easy one to measure. And it follows directly with the pressure in the left ventricle once the aortic valve opens. And then it goes up and down, then it hits a notch here when the aortic valve closes, which leaves the circulation competent, and then it falls away to its lower point there, which is the diastolic pressure. For example, when you measure the blood pressure, you get a reading of 120/80. The 80 is the diastolic blood pressure. The top one is the systolic. Okay, and then the bottom down here where it says the orange line there with all the squigglies, it says PCW, which isn't, it really shouldn't say that. It should say left atrial pressure, which is what we're trying to describe there. The reason for the words will come to you in a moment, but it is a low pressure circulation of the left atrium, and it records up to say 10 millimeters of mercury, so that's the difference. It's a low pressure circulation as long as that valve is intact. Okay, so that's what we call hemodynamics. That's the very basics of hemodynamics. The other thing is a measurement of forward flow, which is called cardiac output. I'm not going to address that more right now. Next slide, Joe. Okay, just to explain this concept of the wedge pressure, it's left atrial pressure is really hard to measure. You can directly measure it by sticking a needle through into the left atrium, but you can imagine there's all sorts of potential problems with that. So that's not done so often these days. What is done is this catheter is passed through a forearm vein or a vein in the leg. And what's unique about it is it has a balloon on the end of it, which you can see in the pulmonary artery branch, the balloon at the end, Joe.
Or at the end here.
Right there. So it's initially deflated, but the catheters pass from where it starts into the right atrium, and then the atrium has certain characteristic pressure patterns. And when you pass through the valve into the right ventricle, that has quite different pressure patterns. The pressure will go up to, say, 20 in systole and then down to baseline. When the balloon is inflated, when the catheter tip is in the right ventricle, it floats along, it's inflated with air. It will float along with the blood flow into the pulmonary arteries. So that's one way of easily accessing the pulmonary artery. What we do then is we deflate the balloon, advance the tip of the catheter a certain distance, and then inflate the balloon. And one other point is the tip of the catheter is distal to the balloon, and that is direct access through the lumen of the catheter to a pressure manometer.
Steve,
so,
can you explain what distal means, please?
After.
Thank you.
Okay. So we're measuring pressure in this area where we've inflated the balloon and occluded flow. So what the tip of the catheter is looking at is the pressure in these distal branches, the further out smaller branches of the pulmonary artery as it goes. That's the blue. Then it turns to purple into red, which is the small branches of the pulmonary vein, and then it comes back into the heart. So there's nothing, there's no valves between these branches of the pulmonary arteries and the left atrium. So in fact, what we're measuring there with this inflated balloon is what we call the pulmonary capillary wedge pressure. This is done at the bedside. This is a really simple thing to do. It came out about early 70s, produced by a fellow called Jeremy Swan, an absolute character of a guy. He's Irish. He used to be a boxer, then he became a Shakespearean actor. and then he went into cardiology somehow, but he's a really interesting guy from, lives in Los Angeles. I think he's just passed away recently. But this concept changed things a lot, and then we could get active real life pressure measurements, life pressure measurements of left atrial pressure, which is a key in managing heart failure. What I didn't say before is that with this failure of the definition, with the failure of contractions or the failure of emptying, what it does, it increases the left atrial pressure, which is the initiating issue in the whole cycle, which causes congestion in the lungs, and that causes shortness of breath. That's fundamentally what it does. So raising left atrial pressure, absent disease of that valve, mitral valve. How do we know that? We look at the heart with an echocardiogram, and we see the mitral valve moving around in the normal way. In the past, mitral stenosis, it was called, which was an end product of rheumatic fever in childhood, was the most common cause of heart failure in younger people. But that's a rare disease now. It's sometimes in older population, but it's quite rare. Anyway, that's what we have to do. We have to know that the mitral valve is normal. It's not thickened. It's not fused. Okay, any questions about that? Because that's also covered quite a bit. No, Joe's clear and Hillary's clear. Okay.
Okay.
All right, let's move. Yeah. Okay. All right, this is what it looks like as a cartoon representation of what somebody comes in with heart failure or acute heart failure into the emergency room. They have to sit upright because lying down they can't breathe. They were sweating because of all the activity of the adrenaline passing around. And if you look at this barbell, it is to represent this weakness and fatigability that's quite profound. And the last thing is these, if you look at the feet, that blood gray area represents swelling of the feet, which goes up into the legs and up into the abdomen. So that's how they present. And the terms on the left, paroxysmal nocturnal dyspnea, represents dyspnea is shortness of breath, okay? That's what dyspnea refers to. What happens when the person is lying flat with heart failure, fluid accumulates in the lungs from the periphery, and they become short of breath, and they have to sit upright to get some relief. So that's what it's a classic term, paroxysmal nocturnal dyspnea from heart failure. It also occurs from severe lung disease, of course, because sitting upright, you can move the diaphragm further and gain a bit more volume in the lungs. The middle term here, elevated pulmonary capillary wedge pressure, I've just explained. Pulmonary congestion, interestingly, they're often the first symptom of heart failure is a cough, a dry cough. It's not the cough of somebody with bronchitis or bad COPD, chronic obstructive pulmonary disease. It's just a dry hacking cough. Occasionally they wheeze. Occasionally there's a little blood-tinged sputum from the backup pressure into those small vessels in the lungs. Tachypnea refers to the rapid respiratory rate, and the crackles refers to when you listen to the lungs, at the bases there are extensive crackles. That's air going through the fluid in the air sacs. That's what causes crackles. So that's what it looks like. The patients are quite uncomfortable, and they're admitted to hospital, and several things are done right away. Okay, next one. Okay, now this schematic, look at the center diagram. That's the normal heart. And if you go to the left, in systolic heart failure, that is weakness of the heart, the left ventricle dilates, it contracts poorly. It can even lead to some leaking through this mitral valve into the left atrium, which compounds the problem. But when we have the capacity to look at it, as we do these days, with echocardiography, that's what you'll see. You see a rounded left ventricle is dilated. The ventricle is not conical like in the normal ventricle, and it's often thinned out. Okay, now on the right diagram, refers to diastolic heart failure, where the left ventricle is not enlarged. In fact, the diastolic heart failure is most commonly due to thickening of the left ventricle, which you see represented there by the pink area, which is my second heart muscle. It's not always the case, but it's mostly the case. So there's resistance to filling the left ventricle in diastole, that is between the contractions. So the left atrial pressure goes up, left atrium gets dilated, something we can also see easily with the echocardiogram. So in summary, that's a systolic heart failure on the left, diastolic heart failure on the right. And the diastolic heart failure generally occurs in older patients. And again, this wasn't well described until the 1980s, I would suppose, but the two are equally frequent. And actually, they have the same outlook. The prognosis for either is not very good, so the mortality is high. Let's look at the next slide. Okay, this is an echocardiogram. And this to show you on the right, that big chamber that's pumping is not the right ventricle, it's the left ventricle. That's just the way adult cardiologists present these things. On the left side, you're looking at the right ventricle. And towards the back, you have the right atrium, and to the right there, to the right there, that's the left atrium, mitral valve. You can see there's two little leaflets opening and closing. That's a normal appearing valve. And this is normal function. It's focusing on the left ventricle again. There's symmetric contraction that's about average amount. It empties. It would be emptying, let's say 60 to 65%. It says up there on the left it's 70%. I don't really believe that. Just a technical point, that's called the ejection fraction, the amount that's emptied each cycle from the left ventricle. And it's normally between 55 and 65 to 70%, but that's in the normal range. This can be measured per computer, and the numbers digitized. There's great possibility of picking out the wrong area. It's the whole concept of edge detection. Those echoes are relatively weak compared to the middle of the muscle, which is brighter. So in practical terms, what we do in practice, we eyeball this, and once you've had experience, you learn what the difference between ejection fraction of 60 to 65 and one that's 25 to 30. That becomes pretty clear. Okay, now the next slide, rather, shows an echocardiogram of somebody who's just had a big heart attack. And you can see the area at the top of the screen there, which we call the apex to left ventricle, doesn't move. The area go to the middle, Joe, middle and towards the back, towards the top, sorry. All this entire area doesn't move. And over to this opposite side here is the left ventricle, moves not at all or very weakly. The entire, that's called the lateral wall over on the right side, Joe. That's it, that's the lateral wall. And the middle is called the septum, interventricular septum. So that's a big heart attack, and that ejection fraction would be in the range of 20 to 25% maximum. You can also see the left atrium is bigger than the right atrium. That's because of the high pressure. This heart is failing, and that's the effect of the poor function of the ventricle. So this is not uncommon. It's fortunately less common than it used to be because of all the preventive methods we have, but that's what we see a lot. That's not a good heart at all. Okay, any questions? Well, just to say that echocardiography started when I was in training, and I didn't really believe it would come to anything, because basically it represented all sorts of artifacts, and it was hard to tell one structure from another. Since that time, the engineers and the computer scientists have done a superb job, and you finish up with data and clarity just like this, not only that, the size of the unit has shrunken from something that's quite big and can't be moved around. These, in fact, are in iPads now, and you just carry the iPad to the bedside. It also has the capacity for other things we do, whistles and bells related to Doppler flow mechanisms, which help us assess function of the heart rather than the anatomy of the structure. So it's very satisfying field to work in. And I would say most cardiology patients, if not all, in a hospital setting get an echocardiogram. That's almost fundamental now. Okay, next one. Okay, so this is a slide representing contemporary treatment on a population of Medicare patients, that is patients over 65, and it's a retrospective study looking at the patient's clinical records and the length of survival. And there are two lines here. There's a blue line which represents the heart failure with a reduced ejection fraction, and the red line represents the heart failure with preserved ejection fraction. So the results, the effects of heart failure either way are identical. Most unfortunate about this is the mortality. You can see at 5 years is about 75%, and it's even relatively higher at 1 year, about 30% further down. So 30%, you present to the emergency room in heart failure, and the way it has been going, 30% would die. Now, the big changes in treatment of heart failure essentially came out in the 1990s, early 2000s. So this is a study from 2017, and these results are obviously appalling. They're really appalling. These are not the results that we get with treatment by cardiologists of the systolic heart failure. Unfortunately, the results with diastolic heart failure, as I mentioned before, not improved. What we're doing with treatment of diastolic heart failure is getting rid of the excess fluid. So we're treating the effect of the heart failure, but we're not treating the cause at this point. Now, there's lots and lots of research going on, but it hasn't been a very rapid evolution so far. So just keep this in mind, because I'll show you, I'll describe one patient at the end of this presentation who lived, in fact, 22 years and with the same sort of thing. So what is the reason for that? I'll describe that. Okay, next one. Okay, the heart fails when there's too much tension in the heart throughout the cycle. So if you take a segment of heart muscle out, like it's done here, there's a certain radius of curvature on the horizontal plane, that black line with the arrows, right? That one here, and then the other black line represents the longitudinal plane. But if you take on the horizontal plane, if I'm making myself clear here, the tension in the wall, which the heart does not tolerate at all, is directly related to two things: the pressure in systole and the pressure in diastole, that is when the heart's relaxing. So given that in the normal heart rate, more time is spent with the heart resting in diastole than in systole, a dilated, stretched heart is the opposite of what is needed. Heart failure, by definition or by observation, is progressive. When, I'll just go back a little bit, in the 1960s, when I got through and started treating heart failure, there became the availability of a very potent diuretic called furosemide or Lasix. And it is still the main diuretic that we use these days. It hasn't changed very much. We sometimes add one or two diuretics that work at different sites in the kidney, but that's our mainstay. Okay, let me just back up. So this is, if you just look at the base of this heart, you'll see that segment has a relatively wide area curvature relative to the apex, which is much narrower. So that is the reason for that, the way the good Lord put the heart together. This was the most efficient way of forming the heart, with higher tension due to the higher radius of curvature at the base, but lower tension at the apex. So this, in fact, led to a heart that is most efficient and becomes less efficient as it stretches and dilates when there's weakness. So let me show you the next slide. This is a patient with a modest size heart attack on the left, acute infarction. Tissue is dead, and the body's reparative tools get to work, and the dead heart muscle there gets replaced over to the right with collagen, that's basically scar tissue. And in the early stages, this area is at the apex there where the heart attack may expand, and rarely it can rupture, but it can. And when that happens, the game's over. That's sudden death. It's not the cause of most sudden deaths, by the way. It is quite rare. But what you're left with, because this area in the yellow is out of the picture in terms of contracting, then the remaining normal heart muscle in the pink, has to do the work of the area that's now completely gone. So the muscle fibers in the heart get stretched, and as they get stretched, they actually contract better, which is good in the short term. But in the long term, there's more tension in the wall of the heart, so the muscle gets weaker and weaker. This is fundamentally why heart failure is progressive. And then you look at the one on the right, you can see how the heart gets dilated, and this heart muscle does not contract nearly as well as what it did before. This occurs over a course of 3 or 4 months, maybe a little longer, just depending. But there's progressive deposition of collagen into the muscle there. And the main point of this is the cells, because of the situation they're put under, they die prematurely, and there's cell death. They also hypertrophy, but that means they thicken, which is a compensatory mechanism, but that doesn't do too much. But this excess stretch from the excess work leads to cell death. So the process continues in a downward spiral. So that's vital to understand that. Any questions there? All right. Okay. All right. Here's some of the risk factors. This is not exhaustive, but the commonest reason for heart failure is coronary artery disease, most commonly after a heart attack, myocardial infarct there. And then beneath that it says ischemia. What is ischemia? Ischemia is imbalance of the demands of the heart muscle for blood supply relative to the blood supply itself. So let's say you have some narrowing, focal narrowing in a coronary artery, so that the flow to the distal area which is supplying that heart muscle is reduced, then that area of heart muscle, short of a heart attack, will become weak, and it can stay weak for quite a long time. That's what ischemia is. Now, typically with ischemia, you get chest pain, which is called angina pectoris, or angina, depending which part of the world you are. But that's typical, but it's not 100% by any means, which is the reason we can't rely on symptoms to tell us of the coronary disease at all, and we have to go to stress testing of various types to sort that out. Now, the next most common contributor to heart failure be hypertension uncontrolled. It's not difficult to control hypertension once the patient comes to the hospital, but it's a public health issue, obviously, to get that controlled from in the outpatient setting. Okay. The third most common cause is cardiomyopathy, which means there's a weakness of heart muscle. That can be due to a variety of things. It can be due to previous inflammation of heart muscle. That's called a myocarditis. And when the heart muscle doesn't recover, it commonly doesn't, then you're left with a dilated, weak heart muscle. That's one reason. Another reason would be excess alcohol. Certain drugs do it. Chemotherapeutic drugs commonly do it. It's something that has to be watched for. And then there's a variety of other things we won't get into right now. And then the other common one under arrhythmias, Joe, it says tachycardia, which is tachycardia is rapid heart rate, and it's commonly occurring, with a change of the heart rhythm into what's called atrial fibrillation. The next slide, Joe, I think we have this is atrial fibrillation, and the next slide is what we call normal sinus rhythm. And I'll just go through it. This little broad wave at the beginning of the cycle there, the broad one here, there, right, called the P wave. No, go back. That's right. No, go back. Right there. No, go forward. There, you're just about there. That's it.
Not here.
That's called the P wave. Right. And that represents that's the electrical signal of atrial activation leading to conduction and contraction. Then this narrow, tall spike refers to what's called the Q, which is a negative wave, the R wave, which is a tall wave, and then the S wave, which is a negative wave. It's called the QRS complex. That represents activation of the ventricles. And then the ST segment is from there over to the right. That's the T wave coming up right there, the T wave, and the end of the T wave there. That represents the end of contraction. And then you have an isoelectric EKG signal between the cycles. Okay, so go back one, Joe. What you see here is a rapid rate. There's a shorter interval between the QRS complexes. It's irregular. It's notably irregular. And there's no identifiable P waves. It's chaotic electrical activity. That is atrial fibrillation. So the characteristics of it is there's chaotic electrical activity in the atrium, and that's about 400 or 500 impulses a minute. The conduction through the AV node slows some of those down. So typically the ventricles will receive maybe 160, 180 of those in a minute. So that's still pretty fast, but it's not 500. And it's irregular because of the function of the AV node. So this obviously is a major factor. Let's go back one, Joe. So if this tachycardia and atrial fibrillation with a rapid heart rate is the most common, if that persists for several weeks in the adults, you'll finish up with weakness of heart muscle. And when we see these people, which is quite common, we don't know whether the atrial fibrillation is the cause, the rapid rate is the cause of the weak heart muscle, or whether weak heart muscle caused heart failure, backed up pressure in the atrium, stretched the atrium, and initiated atrial fibrillation. So it takes time to sort that out. But these cardiomyopathies from tachycardia induced, they're remarkably reversible. And we have people with terrible looking left ventricles return to normal in 3 weeks, 2 weeks, 4 weeks, something like that. And that's when you know it's tachycardia induced. The other forms we won't go into too much. I'm not talking about valve disease or congenital heart disease today. Okay, next one. Next one, go next one again. Okay, so when the heart is stretched like this and the output of the heart is reduced, there's what's called, and I apologize for this, a neuro-endocrine response. And I'm about to describe this. The neuroendocrine response relates to the sympathetic autonomic nervous system, which stimulates the heart, and that's a good thing acutely, and it's a terrible thing chronically. The RAAS refers to another mouthful called the renin-angiotensin-aldosterone system, and I'm just about to go into that as quickly as I can. And the last one that occurs in response to heart failure is what's called a natriuretic peptide. This is a chemical that's produced in the heart, mostly in the atria, and it's released in response to stretch in the atria. So this is a relatively new peptide we've been measuring, I guess for 10, 12 years, and it's basically pathognomonic of heart failure of some sort. It can be from right heart failure alone or left heart failure, but this is what occurs. What the natriuretic peptide does is it works for the good of the heart. It promotes excretion of urine. It's a diuretic, which is a great thing, and it gets rid of the excess fluid. It dilates arteries and it dilates veins. By dilating arteries in a modest way, the resistance to emptying of the weak heart is reduced, so the forward flow, the cardiac output, is enhanced. If it overdoes it, if it dilates the peripheral resistance, these small arteries, too much, then the blood pressure will fall. But in a balanced situation, which it usually is, just from the natriuretic peptide, it dilates the small arteries. It also dilates the pulmonary veins and the systemic veins in the body. And by dilating the pulmonary veins, the pressure in those veins and in the left atrium, by definition, falls. So that's really adaptive. So natriuretic peptide is highly adaptive. The other two, for the long term, are maladaptive. Okay, next one.
Can I ask you a question,
Sure.
Dr. Cantor?
Yeah.
So these peptides are kinds of proteins?
Well, serial peptides make up a protein. It's a breakdown of a protein.
And where are these produced in the body naturally? Where do they come
in
from?
the heart?
In the heart. It's actually
Yes.
producing them.
Yeah. So there's a baseline level, obviously a low level, which is measurable in the normal heart, and that goes up with stretch. It goes up fast. It's really a very handy test, to have. But that's only the last 10 years or so we've had it to use, but that's changed things quite a bit. Okay.
And when you speak of neuro-endocrine, endocrine is also some kind of a...
Well, this is, okay, the endocrine represents two hormones in the body. So I'm not referring to cortisol, I'm not referring to estrogen or androgen or so on and so on. This is just three of them. Okay.
And those are produced where? Also in the heart?
Okay, the sympathetic nervous system it's a stimulus from the brain to the sympathetic nerves, which go to organs, all organs, and all arteries in the body. And there's a small area of tissue called a ganglion, which produces adrenaline and a byproduct noradrenaline at the tissue level.
I see.
It also, one other point, it stimulates the core of the adrenal gland, called the medulla, to produce adrenaline as well. So there's two mechanisms, one by direct stimulation of the nerves and the other is direct stimulation of the adrenal medulla. So that's where you get that from. The renin-angiotensin, I'll explain. I think the next slide is coming up.
Okay, thank you.
Yeah. Oh, okay, the sympathetic nervous system, the stimulus for that is from pressure receptors in the aorta, in the carotid arteries near to the heart, and they're very sensitive. So once the pressure goes down in the aorta, goes down just a few millimeters, there's this direct signal to the heart to stimulate it, and this leads to the broad arrow there. As I say, acutely, that's a great thing, but chronically, it's not. And this was this recognition occurred relatively late. It was in the 1980s. When I was a resident in the 60s, the one thing you never did, you don't really use the term never in medicine, but you practically never did, was to give beta blockers to somebody in heart failure. because if you give it in a standard dose, they would decompensate and die. So, however, the Swedes had a long-term study, and they really into the molecular biology of the myocardium. And they reckoned that they recognized that there was a lot of adrenaline stimulating the heart. The receptors, which a certain number were increased, there were more receptors, but there was less responsiveness. So they came up with the idea that they would give a very small dose of an adrenaline blocker, beta blockers. And in fact, they found that there was some minimal improvement in the function of the heart. So little by little, they added a higher dose over a period of a couple of months. And in fact, they found ultimately, I say by 4 to 6 months, the heart muscle was really dramatically improved. So this is the first time that was found. Unfortunately, in that early phase, as you're titrating the dose of the beta blocker up, few of the patients, quite a few, can decompensate. So they haven't quite adapted. And you have to find a way, if you can, to get through that 4-week interval, basically, until they adapt to that small dose of the beta blocker. After that, then you can progressively increase the dose. And so the studies, the long-term studies of beta blockade, there were 3 of them really that were effective, showed if you did it very cautiously, increasing one of these 3 drugs, then you would get a dramatic response. The mortality was reduced by 1/3. Symptoms were markedly improved. Exercise capacity was radically improved, and the patient felt better. Okay, so this was the first breakthrough. Okay.
Oh, so Dr. Cantor, a couple of questions, excuse me, but
No.
ask questions to the group here. This phrase you used, was it chronically it's a good thing, but it's a bad thing, but acutely it's not? Can you repeat that?
Oh, other way. No.
Yeah, I know, I got it backwards. Could
That's
you
okay.
explain?
But you asked the question, which that's the important thing. So acutely, the stimulation of the sympathetic nervous system and the production of adrenaline is quite adaptive. It's an excellent thing. It keeps us alive. But that's for the acute situation. But in the chronic situation, I'm talking about weeks and months, that for the heart is a bad thing. And that was the big breakthrough to find that. We just didn't know that until the 1980s. And that led to the introduction of the use of beta blockade, beta blockers. Okay.
Thank you, but I have a second question.
Yeah,
now, you talked earlier about damage to the heart muscle because of chronic hypertension, and that doesn't, the heart muscle in that case that's damaged does not heal, right?
Okay, yes, that's right, because it's the high pressure and the tension,
right?
High tension in the wall.
But you talked here about improvement after so many weeks of treatment.
Right. Well, that's not related to hypertension. In fact, what you're wrestling with is the opposite of hypotension, inducing a low blood pressure from blocking the effect of adrenaline. That's the struggle that we have in those first couple of weeks, to be able to introduce low doses of beta blockers without making the blood pressure too low. When the first of these came out, there's a presentation on a drug called carvedilol, which was studied mostly in this country. And they had a patient there who couldn't tolerate the lowest dose. The blood pressure fell from about 95 down to about 80. And she couldn't stand up without feeling lightheaded. And they persisted with her. They gave her some extra salt, actually, which improved the blood pressure, helped to tolerate the carvedilol in this tiny dose, so that in about 2 or 3 weeks, she could tolerate it. So blood pressure would return to baseline after initial area, a time of low blood pressure. So you can imagine the average office doctor just doesn't want to get involved in this. So this is hard. It takes time, and this is where cardiologists and some internists also do this, but predominantly cardiologist. It takes a lot of time to sort of handhold these patients through, but it's really important. Okay.
Thank you.
Okay.
Next
All
slide.
right. Okay. Okay. This is the terrible renin-angiotensin-aldosterone system. I can tell you stories about this. There was a wonderful professor of medicine from the county hospital in San Francisco who came out to Melbourne, where I was before I came to this country. And he was, his name is Ed Bilieri, Dr. Ed Bilieri, and he was a specialist in studies of aldosterone. You can see over there. Aldosterone is a normal hormone that helps regulate salt and water metabolism. It's also aldosterone excess leads to high blood pressure because it retains salt and water, which made sense, but it was a rare finding. I think he said when he came out that he would find about one every couple of weeks, which he did. And this stimulated a lot of excitement amongst the young upcoming researchers and doctors. So the following year, I think he had 5 of these researchers from Melbourne working with him in San Francisco, which the following year when I came over there as well. But that was interesting. He's a lovely guy, Ed Bilieri. He's recently passed. But anyway, so this is all based on the beginning of all this story of this RAAS is the renin just above the kidney. Okay, is released. Renin is released when there's a low pressure of blood entering the arteries of the kidney. So the same as for the sympathetic circulation that I've just described. So that's the stimulus for it. And it works on a precursor of what is called angiotensin. This precursor, angiotensinogen, comes from the liver, and then renin converts it to angiotensin 1. And in the lungs is an enzyme called angiotensin converting enzyme. That's a mouthful, but that's what it is. Called ACE. And the ACE converts angiotensin 1 to angiotensin 2. What angiotensin 2 does is 2 things. The first is not shown. It works on the tone of the muscle in the small peripheral arteries that modulates the resistance to emptying of the heart. So that's one action. The other action is to, by having a reduced amount of angiotensin, then you reduce the resistance to emptying the weak heart and you enhance forward flow. So that's one of the ways that helps heart failure. And the other way is that it also stimulates the adrenal cortex, the outer layer of the adrenal gland, to produce this normal hormone, aldosterone, which works on the kidney to optimize salt and water control. It brings in salt and water, it excretes potassium. Okay, so they're what we're looking at. The key things here is the activity of renin to produce angiotensin, essentially via this ACE, the angiotensin converting enzyme, and the angiotensin leads to production of aldosterone. That's the guts of this. Okay, let's go to the next slide. Okay. ACEI refers to ACE inhibitors, and there's a slew of them. I'm not going to give you the names because you'll have to get that from the doctors. There's so many of them. They're all kind of Me Too drugs. After the first one was called captopril. There's all these other ones out there, but they essentially do the same thing. So they block the effect of ACE to form angiotensin 2, which is the active form of angiotensin. So that's one thing we do. The beta blockers I've just mentioned. And then lastly, this should be first, when a patient comes in unstable or with short of breath, the first thing we do is give them a diuretic to relieve the excess of water, which will be in their lungs. And if they're swollen up, we reduce that, we diurese the fluid from the systemic circulation starts in the legs, goes in the abdomen, you have ascites, abdominal distension, and so on. So the diuretics, as I said, are very potent, and they're effective in most cases. It's unusual for them not to be effective acutely. In the long term, the diuretics do nothing to the natural history of heart failure at all. So that's the important thing. So they make patients feel better. And so what the scenario that happens is this. The patient leaves the hospital, stabilized, they've been diuresed, they're on furosemide or Lasix, it's the name of the drug, and they go to the primary care doctor and the patient's feeling fine. So the primary care doctor may well pass on the situation. The patient's comfortable, no complaints, but these people need to be referred to people who work in the field and cardiologists because they have this weak heart. Maybe symptomatic, may not be at this stage, but blocking these neuro-endocrine receptors, the aldosterone, the angiotensin, and the adrenaline are key. And it takes a lot of hard work to get all this done. This second blue box refers to the MR antagonist. That's mineralocorticoid receptor, that's a rotten term. That refers to aldosterone. I don't want to just say that. And lastly, another drug has come out just to complicate things, which is very important. Go to the next slide, Joe. Next slide.
Yeah, just a sec. Okay.
Okay. So this shows, it's a schematic showing heart failure stimulating the SNS, the sympathetic nervous system, the RAAS on the right. And on the left is NPS, which references the naturopeptic system. Now, the naturopeptic, the peptide is advantageous. And so what's happened here is the breakdown of the peptide comes from something called neprilysin in the liver. And by blocking the effect of neprilysin, you enhance the level of the naturopeptic peptide, which changes the natural history of the weak heart muscle. So they combined, the researchers combined a blocker, which is a neprilysin blocker called sacubitril, with an angiotensin receptor blocker. That was important because when you enhance the natriuretic peptide, you also increase the amount of angiotensin too. I'm not going to go into why, but it does it. So those two have to go together. But when they did that, this came out about 2012, and it showed a 23% reduction in mortality relative to the use of an ACE inhibitor, which had been used in the landmark trials 20, 30 years before. So this changed things, and more it's recommended that people with heart failure due to reduced ejection fraction should go on this drug called Entresto. The downside of it is it can drop blood pressure by dilating the arteries. You've got to watch for that. It can elevate potassium by blocking the effect of the ACE inhibitors. So you have to watch that. It can aggravate kidney function by reducing flow to the kidney. All these things have to be worked around. But you can see in the bottom left there, it enhances vasodilatation, it reduces fibrosis, and it promotes natriuresis or diuresis. Okay? Again, that's quite a bit, but that summarizes basically the drug pharmacologic approach to systolic heart failure, with the one exception. Since I retired, there came out a drug, a diabetic drug used to lower blood glucose. It works by excreting glucose in the kidney and maybe some other mechanisms. And it was found in diabetics with heart failure. It absolutely enhanced the function of the heart and improved survival. The next thing was that it was given to people who don't have diabetes, and the worry, of course, is it would produce a low blood glucose, hypoglycemia, but it doesn't. So in fact, this drug, it's a whole category of drugs. It's under the heading of SGLPTS2 antagonist. So that's a mouthful. I'm not going to spend time on that. But that's added to what I've already presented just in the last couple of years. And it's not not reached the evidence, not reached what we call class 1 indication, but it's getting there. It looks like it will be a class 1 indication. So you might hear about that. Okay, next one.
And I think, Dr. Cantor, we have to keep an eye on the clock too.
Yes, we do.
Okay, just
okay.
a reminder.
Yes, I'm looking. Okay, pass that one. Pass that one. Okay, so this one represents a coronary artery, and this represents what we call plaques. These are areas of narrowing, which is what coronary artery disease is, which is disease in the inner lining of the heart, of the arteries, of the coronary arteries supplying the heart muscle. And these are things that develop in adolescent years. That's when they start. There was a study done on Korean servicemen who died in the Korean War. Autopsies showed there was a surprising amount of plaque in 20-year-old men. So that's where this concept arose from. So over the years, with the right risk factors, these plaques become more severe. And at some point, there's a surface cap made of fibrous tissue. Some point, there's erosion of the fibrous cap. And then that's rupture of the plaque. And what that means is the blood has direct contact with the contents of the plaque. And some of these contents activate what's called the coagulation or clotting mechanism of the blood. So this purple area represents agglutinated red blood cells, which is part of the clot. Okay, so red blood cells agglutinate, then it leads to, they're connected by some fibrin, and that forms a clot. This is the sort of clot you get typically in a vein with a stasis of blood, let's say from deep vein thrombosis. In the arteries, it's just a little more complicated. The platelets in the blood, the sticky cells, become sticky when they're exposed to certain chemicals. There's what's called a tissue factor in the plaque that leaks out once you get a rupture. And that activates this agglutination of platelets. There's a chemical in the clot of the red blood cells called thrombin, and that's a potent promoter of sticking of these blood cells. So the platelets add to this clot that's forming, so that the clots in artery are actually predominantly from platelets, and that leads to what's called a white clot. So the white clots are typical of arteries, the red clots are typical of veins, and there's a bit of a combination of these two here in a ruptured plaque. When this happens, the natural history is for the clot that's developed to progress rapidly and occlude the vessel. Against that tendency is the body's own mechanism to break this clot down. But if it's outweighed by the volume of clot that's formed, then you will have typically a heart attack. And when you have threatened heart attacks that haven't quite reached that point, it's due to a plaque like this that hasn't quite occluded the artery. But there's a battle going on between the proclot and the anti-clot mechanisms of the body. So this is vital. This is what causes heart attacks. Now there are lots and lots.
Lie down for 45
Yep,
minutes.
yep.
Okay,
I'll see you at 5 o'clock for Scrabble.
okay, bye.
I'm sorry.
Sorry about that. Go ahead, Dr. Cantor.
Oh, okay, next slide, Joe. Okay. One of the things that happens with coronary artery disease is when ischemia occurs. I just described that, typically causing angina pectoris. And this is what occurs with acute ischemia. We can induce this by a stress test, typically by exercising a person on a treadmill And as you exercise, the heart has to work harder. It needs more blood supply so it can do this. But if there's obstruction of coronary arteries, there's a discrete limit to how much blood can occur. And once the demands of the heart are exceeded, then the area supplied by that narrowed artery becomes ischemic and it stops contracting. So you can see the area on this right one becomes mustard shaped. Yeah, over here, left.
Left, okay.
Okay, yeah, okay. And what we see looking with the echocardiogram is a segment of the heart muscle which did contract. At the peak of exercise, it stops contracting, and that's what we look for. That's one way of looking for ischemia or underlying coronary disease by using a stress test. Okay, that's what that does. Below that, the referring to the hypernating myocardiums are different kettle of fish, really. This is what occurs in the chronic condition where the heart muscle is ischemic chronically so that the cells stop contracting, but the process stops short of causing death of the heart muscle. So it's not a heart attack. What you see looking at it is an area where the heart muscle doesn't contract or contracts only weakly. And there's various ways of sorting that out. And that's called viable myocardium. It's weak, it's not contracting, but the tissue is still viable. The concept being that if you restore the blood flow one way or another, you can restore function of that area of heart muscle. So, okay, next one, Joe. Okay. Firstly, it can be done by placing a coronary stent, which is on the right there. You can see a deployed stent in an area. If you go to the left, number A, Joe, yeah. So you see a plaque with restriction of flow. What is done is a catheter is passed from the arm or the leg up to the aorta there where coronary arteries arise, and the catheter is inserted into the relevant coronary artery. In that catheter is a very fine wire which retains torque, and there's a very floppy end which is there to not cause damage to these narrowed areas. If you put a stiff wire into these narrowed areas, you're liable to lift it off and include the artery. So they're very floppy, soft areas at the end, far end of the wire. So the wire is steered through the catheter, through the narrowed area. Then over that wire is a very small balloon. It's about size 4 French. That means anything with a deflated, very small catheter with a deflated balloon, which is passed to the site of the narrowing. And on this deflated balloon is a collapsed stent. And once the balloon is opened, it deploys the stent, which between the two of them, they crush this fatty plaque, this area of narrowing, into the wall. And then the catheter, the wire, and the collapsed balloon are withdrawn. Now, without the stent, there's a certain amount of recoil, so that you might find, a beautiful result right after doing this. But if you don't deliver a stent, there's a 35 to 40% chance of re-narrowing, so you defeated your purpose. But the stents are very effective. They hold the artery open. There's some damage to the inner lining of the artery, not surprisingly, by this kind of crude method. When this all started, I didn't believe this would actually work, but it works all right. So now these days, there's a drug coating on this stent, which inhibits this sort of inflammation you get from the damage to the wall of the artery. And that inhibited it, so this re-narrowing, which used to be about a third of all the balloon angioplasties we used to do, inhibited it to down about 4 or 5%. So that's been a dramatic improvement. So this can be done in one vessel. It can be done in 2 vessels. It can be done in 3 vessels. But the more vessels you work on, the more the possibility of complications. So generally, the stent placement is usually confined to one or two of these arteries. They're marvelous. They're the go-to mechanisms with a threatened heart attack in the early stages. That is the way to go. But you have to get there within a certain time frame, usually about 4 to 6 hours from the onset of the chest pain. So that everybody has to hustle. It's a high pressure situation, but that's called primary stenting for heart attacks. You can get there in time. So that's that. Secondly, the next one, Joe. Yeah, that's right. This shows a coronary artery bypass, initially done in the 1960s, where there's a bypass, in this case, of an artery in the back of the chest wall that you can actually do without. So it's stripped from the chest wall, branches are ligated, and it's attached distally at the end to an area that's a vessel, an artery, that's narrowed upstream. What's great about this artery to artery grafts survive much longer than vein to artery grafts. But there's a limit to what you can do with the artery. There's only so much length. And sometimes we have to work on the back of the heart where the branches are. And that's where the veins come in on the left. So this is a saphenous vein from the leg. It's inverted to, so the veins, valves don't become a problem. And it's attached at one end to the aorta and the other end to the coronary artery. Okay, down here. And this is where the skill of the surgeon really is dependent on. Some people are good at it, some people are not so good, and some people are superb at it. That's just the way it goes. But it's so. These vein grafts typically occlude at the rate of about 10% a year. However, I've seen many of these grafts, vein grafts, at 25 years post-surgery that are still functioning. So there we go. So there's a variety of things, but the arterial grafts, internal mammary artery, they don't fail very much. So that's how it works. Overall, coronary artery bypass can bypass more areas of narrowed coronary artery, so what's called multi-vessel bypass surgery. And that stood the test of time. So that this is the go-to method for what we call multi-vessel, 2 and 3 vessel disease, basically. And in the long term, it holds up much better than the stents. Now, the stents, if we keep going back to hospital and getting these the narrowed areas, complicated areas, re-inflated and re-stented, then the end results actually are the same as the bypass surgery, but you spend a lot more time in hospital, which most people don't want. So there's always that discussion between the cardiologist and the surgeon about which way to go, and the patient has a preference, and then you decide which way to go. Okay, that's enough of that. Okay. Heart failure with weak heart muscle leads to its endpoint of death by one of two mechanisms. One is progressive pump failure, where there's progressive shortness of breath, progressive weakness, and progressive fluid accumulation. In the other half of cases, it occurs suddenly due to this disorder, ventricular fibrillation. So it's electrocardiogram of this chaotic rhythm of the left ventricle. It has no effective pumping action. So this is death, effectively, unless you can get to it. You have 2 or 3 minutes to do that. So next slide. Some smart people in Yale University in the 70s and 80s came up with this idea of maybe you could put a defibrillator in, which is essentially a pacemaker placed under the left clavicle there. These leads are passed into the vein, the subclavian vein, going to the left arm and passed to the heart. And this dark lead goes into the right ventricle, has at the far end of it, there's a coil, which is where the electrical charge comes from. And the charge, the shock to eliminate ventricular fibrillation comes from down there, the coil in the right ventricle, and it's directed towards the can of the defibrillator. That's the axis, so that this electrical shock covers the heart. Because a shock of about 40 joules, and it's effective in the vast majority of cases, the vast majority of cases. So this is life-saving. So if people have moderately severe disease, this does wonders. If people have end-stage heart disease where they're going to die anyway, it doesn't really change the natural history. But anything between that and a low ejection fraction, that is about 35% and less, this is what is indicated. Next slide.
Dr. Cantor,
Yeah.
I take it that the patient is well aware if they are receiving 40 joules of shock.
They're aware. They're real. It's the biggest. It's dramatic. It's very painful, and the patient hates it. But if they're alive after, which they usually are, that's good.
Okay.
Okay. I won't go into stories, but yeah, this shows you how a defibrillator works. This is an organized rhythm, but it's rapid, going about 185 a minute. This is ventricular tachycardia, which in fact is the precursor of ventricular fibrillation. And so there's a computer algorithm in the defibrillator, which goes through the various criteria, certain rate, certain morphology from the electrocardiogram, and persists for over a certain period of time. Then a shock is delivered. And this is what the shock looks like, and it restores normal rhythm. So that's the life-saving effect of defibrillators. Now, it's indicated in all patients who have heart failure with a reduced ejection fraction and expected lifespan of over 1 year. It's not inserted as much as it could be. It's inserted about less than 25% of the time that it could be. One of the reasons is people don't like to have electrical external bodies in their body, a few people. But the real reason is these things cost roughly $40,000 per defibrillator. And in the United States of America, for better or worse, mostly they're placed, sometimes not in the indigent population for economic reasons. In other countries, less wealthy, particularly Great Britain and where I'm from, Australia, they're not placed as often. I was at a meeting of the Heart Rhythm Association some years ago, and I was sitting next to a cardiologist, well-known from Melbourne. I'd met him before I left. And he got up and he said to the audience, we were trying to tease out what the indication for these expensive devices were. And it was the low ejection fraction was the most reliable one. So that was the indicator. He said the indication they used down there for a defibrillator was when the cardiologist said so, which struck me as quite a different set of circumstances, which there are up to a point in that country. The cardiology there is superb. I'm not trying to criticize that, but it comes down to the capacity, the economic capacity of the insurers and the government to afford them. So that's been an issue. They're still around $40,000. They haven't come down. So the last slide, Joe, I'm just about there. It relates to, this is the electrical pathways of the heart. I won't go into it anymore, except to say that beneath the AV node, the pathway is divided into two, one for the right ventricle and one for the left. Right there on the left, when the left bundle is blocked, it's just a part of the process of damage. Not there, no, the left side. The left bundle, yeah, right there. Yeah. When that is blocked, it's as part of the damage to the myocardium, the heart muscle, that the bundle branches, which is specialized myocardium, but they conduct electricity very well. When that's damaged, then the synchronous contraction of the left ventricle is gone, and that's called dyssynchrony. On the next slide. Next slide. Okay, this will show you on the left what in fact happens. So the blue area gets normal conduction. It contracts what it normally does, but on the pink area, that gets delayed activation. So what happens when the blue area is contracting, the pink area is relaxing. Now blood is going sideways. And that's absolutely not what you want. That just increases the distension in the chamber that aggravates the function of the left ventricle. So this in itself, starting with initial damage, will aggravate the heart failure and turn things in the wrong direction. However, if you can restore the situation with a pacemaker, which it can be placed outside the left ventricle on the right, Joe, on the right, yeah, on my right, yeah, there, right outside the little veins there. And we have the capacity to pass electrical lead down to the area of delayed activation. When we fire that, at the same time as we fire a pacemaker on the other side of the heart, then the left ventricle, its synchronicity is restored. So it's within about 100 milliseconds as opposed to 150 milliseconds with dysynchrony. And that dramatically turns around the function of the left ventricle. Let me present this case, and we're going to be just about done. I had a patient, one of my favorites, of course, who I picked up in 1996 when she had a big heart attack. Her ejection fraction was about 15%. It was a large area, the front wall of the heart, which was damaged permanently. That heart muscle became replaced with scar tissue, and that became permanent. She had narrowing all three arteries of the heart. She had coronary artery bypass, those arteries, got through that fine. Then we initiated her on this regimen of these three pathway blockades that I've been through with you. She tolerated everything well. We're able to get to the recommended doses, which is not always done. And then in 2012, she got a left bundle branch block, and she had this scenario here. She became symptomatic, and her ejection fraction went from 35 to about 20%. So we had the capacity to put a pacemaker lead to the vein outside the heart. This is called cardiac resynchronization therapy or biventricular pacing. Anyway, we restored her function, and she became asymptomatic, on the same meds, went back to the cardiac rehabilitation class, continued exercising, and in 2018, the time I left, I took an echocardiogram, and I was amazed to see that her ejection fraction was almost normal, to the point that I thought this might be a mislabeling. Something had happened here which I didn't resonate with me, and I've been looking at things for quite a while. The scar tissue hadn't been eliminated completely, but almost. And that's not the sort of thing we normally see. Scar tissues in heart, they generally don't shrink that much because the heart's working continuously, is what we think the reason is. Anyway, everything had gone in the right direction, and this lady now had an ejection fraction of 45%, near normal. And that was after 22 years. And if you can recall that early slide showing you that the 5-year mortality of heart failure of reduced ejection fraction was 75%. So this lady was at 22 years. And I mentioned this, I don't have all the answers, but this is what can be done. And I think the reason for the poor results in that study was one of two things. One factor is that these patients, some of them are so sick they can't tolerate these medications in necessary doses. That's one reason. But the most common reason is failure of distribution of knowledge, a real inertia within the medical community, and these people don't get to the right specialists to do this. I'm not saying that the average would be 22 years. I'm not saying that at all, but it would be much better than 80% or 75% in 5 years. That's it. Okay, next slide, Joe.
All right.
Oh, that's the last one.
Last slide.
That's what it looks like. There's the left ventricular lead. Next slide will be the last one. Okay, so what can we do to prevent all these things? That's that's really where it's all going. And there are a number of things here. Basically, leading a good, healthy lifestyle is what will do it in the majority of cases. So regular physical activity, keeping a healthy weight, avoiding obesity. Obesity triggers all sorts of things. It triggers sleep apnea, which in itself triggers high blood pressure. It triggers atrial fibrillation, strokes, and kidney problems. And it's progressive downhill course. I haven't talked about obstructive sleep apnea, but that's epidemic in this community where I live. I'm not sure 5,000 feet in sea level are the same, but it's something we have to watch. Smoking is well known for many years, and I don't think you can smoke in Berkeley. I think is that right? Even outdoors, I'm not sure, but that's what I think is okay.
In certain outdoors, even if occasionally not even outdoors, if like too close to a building or other public spaces.
Yeah, it might be. Your health might be endangered, I think. Okay, healthy eating, and they're referring there to vegetables and fruit and those sort of things, referencing the Mediterranean diet, which is in itself been shown to reduce the incidence of coronary artery disease. There are other medical conditions that need to be treated and treated well. High blood pressure is one. Controlling diabetes, that has to be done for a lot of reasons, but controlling diabetes until 2 years ago really didn't do anything to prevent coronary artery disease and heart failure. It just didn't. It prevented kidney disease to some extent. It prevented peripheral neuropathy. It prevented cataracts by tightly controlling diabetes. But it was only in the last 2 years that this new agent, the SGLT2 inhibitor, in fact, reduced heart failure, and the exact mechanism is not known, but it's very real. Okay, so that's the story on diabetes. Maintaining healthy cholesterol levels. They're referencing here mainly the LDL. That's the one that does the damage. Low density lipoprotein is what it's called. And thinking has changed over the years. The statin drugs that you may have heard about first came in the 1980s, a drug called Mevacor. There have been many of them produced since, varying potency. But the long-term benefit of the potent ones, I'm referring to atorvastatin and that sort of drug, they get the LDL levels down very low. So what's been done in the last 20, 30 years, it's been clear that lowering the LDL levels to dramatically low levels reverses the coronary artery disease. And by dramatic, I mean, let's say normal would be 100 and less. They're talking down to 30 and even lower. And it doesn't seem to be any evidence that lower is not better. You might think it would be, because you need LDL cholesterol in your tissues, you need it in the nerve fibers and so on. But so far, that's what it is. So there's certainly a push for people with some risk factors. One of the risk factors, unfortunately, is age. So people over a certain age group, however you define it, we will try and get the LDL down by diet and exercise, but you don't get it down that much. And to get the LDL, the target is under 70. That's the sort of magic number we talk about. Even in people with the problem of age, but nothing else, is advised strongly now. Now, there are a few side effects. The side effects are temporary if you stop the drug, and you can work around those. There's all sorts of stories about how statins are terrible for you. They're not terrible. They are one of the real magical drugs developed in the 20th century. It really is. Heart protective medications. The only thing I'll say about that is the use of aspirin. This has gone back and forth over the years. If you've had a heart attack or you're known to have coronary artery disease, you definitely should take aspirin. What it does, it blocks the platelet stickiness. These were given in a study in Oxford in 1985. It was published, and they found that taking an aspirin in the emergency room and then daily after that reduced mortality of heart attack by 25%. So that's dramatic. That's really extraordinary, I find. But for the person who doesn't have coronary artery disease, the risks of bleeding, and particularly intracranial bleeding, which is usually fatal, outweighs the benefit. So there was an article yesterday in the New York Times. There's more talk about it, and people are moving away from that when there's not a real a risk factor for heart failure. So there it is. It's quite a story of all the changes. I'm not the least bit pessimistic about the future of heart failure. Just giving you what I've seen over the years, but it has to be done in the right set of circumstances. The ideal circumstance is a heart failure clinic where you have dedicated staff, cardiologists, nurse practitioners, social workers, pharmacists, should I say. All these people need to interact, and it's
I don't know if you can hear or see us, Dr. Cantor, but your feed appears to have stalled. No, not yet. Do you have any ideas, Hillary, on what he might do?
Not other than what he's just done.
Yeah, he's gonna have to come back in again. Well, I know this presentation is going a lot longer, but it's just a complicated subject. Hopefully we can get Dr. Cantor back for any final questions, but we will have to see.
Maybe he can give us some reading references.
Yes, I can ask him to do that. I can also try to call him, and why don't you just give me a moment and I'll try to reach him. One last question. Is it possible to have too high of HD cholesterol?
No, the answer isn't. I mean, it can't be. There are about 5, I think, or 6 different products of subtypes of HDL, and they don't all do the good things that it's supposed to do. That is, absorb cholesterol from the body, from the arteries and so on, and bring it back to the liver. That's what HDL does. But it's only some subtypes, like a couple of those 6, that do it. So you got to break it down. There's a character in Berkeley. He was an endocrinologist, actually started practice same time I did. His name's Ron, something like that. He works at UC Berkeley on these. It's what they call an electrophoresis, HDL, LDL electrophoresis. So they break down these into these subtypes, and you can figure it out. So exercise increases it, some alcohol increases it, genetics, you know, if you're so favored, but it hasn't. Any drugs to increase the HDL haven't worked out. The one drug I know that came out increases high blood pressure and increased mortality from that. So there's nothing. So people have moved away from researching on HDL. So my caution would be to think about the LDL. That's where the action really is.
I see.
You know?
Okay. Any last questions from anybody here?
Come on.
Thank you.
Do something.
No. Okay. Well, people are shaking their head no, but let me just thank you very, very much for your time today. And that was a long and interesting presentation. Thank you very much.
Yes, certainly was, Joe. Joe, I recommend a glass of red wine. About now. About now.